Now, without any further ado, through the relationship with Belmont Village and UC Berkeley, it is my pleasure to introduce to you Carrie Sweeney, the director of UC Berkeley Retirement Center. Carrie, thank you so much for being here today.
Hi, thank you, Jackie. It's great to partner. It's good to see everybody here today on this important topic. I have the pleasure of introducing Dr. Kim, who's going to help us better understand this disease today. Dr. Sarah Kim is the Associate Clinical Professor of Medicine and Director of the UCSF Diabetes Teaching Center. She received her MD from Tufts School of Medicine and did a combined internal medicine-pediatric residency and adult endocrine fellowship at UCLA before an advanced diabetes fellowship at UCSF. She's Associate Clinical Professor in Endocrinology and Metabolism at UCSF at the Zuckerberg San Francisco General and directs the UCSF Diabetes Teaching Center Restoration. And we are very happy to have you here today. Thank you, Dr. Kim. I'll hand it over to you.
Thank you so much. All right, so I'm going to share my screen. And do slideshow. Are we good? Good. Okay, thumbs up. So thank you for your attention. I'll be talking today about understanding diabetes and pre-diabetes, talking about risk factors and prevention. So I like to start off my diabetes talks with this graph. It's the data taken from the CDC website. And since the 1950s, the US has tallied the percentage of people in the United States who have diabetes. And so this graph illustrates that in the yellow, that's the percentage being on the left-hand axis. And then the sheer number of people in the blue line with the axis on the right. And you can see actually in the 1950s when we first started counting, the percentage of US adults with diabetes was really low, it was about 1%. And it steadily has increased over the decades and has certainly taken a different slope, a much more accelerated pace in the 90s. And so I'll give you some statistics on how much diabetes affects us today, but clearly we can see there's been a tremendous growth in this disease in the US. So the interesting thing about diabetes, as I'll explain, is that it's very closely related to obesity. And what I'm going to show you in the next several slides are heat maps of the rates of obesity per state. And so the darker the state, the higher the prevalence. And also the heat map for diabetes alongside of it. Again, the darker the state, the higher the prevalence. And you can see here's the first time the CDC published data in this form in 1994. And then we're just going to go through time, 1995, just looking at sort of in a broad way how the colors are changing. 1996, 1998, 2000, 2002, that's when we had to add more colors because of the higher prevalence of both conditions. 4, 06, 08, 2010, 2012, 2014, 2015, and a broad view. So you can see here the obesity heat maps on the top and the diabetes heat maps on the bottom in 1994, in 2000, and then finally in 2015. You can see that we've gotten very dark over the decades. And if you kind of look in a sort of a broad way, the patterns of the obesity rates are followed closely behind by diabetes, because obesity and overweight are a strong risk factor for diabetes. When we reflect back on that first graph I showed you where diabetes seems to take off, especially since the 90s, it is really on the tails of the obesity epidemic, which has taken off in the US. So how is diabetes affecting us today? This is a snapshot. I pulled this infographic from the CDC website. So 34.2 million Americans have diabetes, and that is currently about 1 in 10 of us that have diabetes. Many more have pre-diabetes, but the officially diagnosed diabetes is 1 in 10. And of those people who have diabetes, about 1 in 5 don't know they have it. So they haven't been properly diagnosed by their physician and know that they have this disease. So it's a very common condition. I borrowed this infographic from the American Diabetes Association, just some sobering statistics about the cost of diabetes in our nation. So 2.3 times greater healthcare costs with Americans with diabetes compared to without diabetes. And this is roughly estimated at $327 billion annually for the medical care of diabetes, and including loss of productivity. So down here, 34 million Americans have diabetes. And this is sort of their heat map of the rates of diabetes in the country. And to Carrie's point, or to the introduction, 88 million people have pre-diabetes. And so that is a condition that's not quite yet diabetes, but the laboratory tests are not normal, and they're hinting at possible diabetes in the future if things don't sort of change for that person. Today in America, 4,000 people will be told they have diabetes. 356 people today will have an amputation related to diabetes. And 159 people will start dialysis as a consequence of diabetes. And it's an expensive disease for a lot of the complication reasons, but also the medications are quite expensive and hospitalizations are quite expensive. And so 1 in 7 of our healthcare dollars are used to treat diabetes and its complications. So it's a very important condition that affects all of us, whether we have it or we don't, in some way or another. California is no exception. So 4 million Californians have diabetes, and our rate of diabetes is higher than the national average at 13%. Okay, so I like to talk about this part, which is, what is diabetes? How do you understand diabetes? Why does it happen in our bodies? What's going on? So fundamentally, diabetes is a problem with carbohydrate metabolism. When I say metabolism, I mean when you ingest carbohydrates, how your body processes and utilizes the nutrient of carbohydrate. Okay. So carbohydrate is a very common nutrient. You know, there's like 3 different nutrients in our food: either carbohydrate, fat, protein, and then there's fibers, 4. And carbohydrates are the things that probably we're all familiar with: grains, fruits, dairy. So very popular in our diet, and also can be quite healthy in our diet, so long as we choose the right ones. And diabetes is specifically an issue with processing carbohydrates in the body. So this guy is eating a sandwich that has bread. Bread is a carbohydrate. And as he digests this bread, the bread actually becomes little pieces of sugar in the intestines. And we call this sugar glucose. Glucose is just scientific word for one type of sugar molecule that carbohydrates become. So this gets a little scientific, but I think you guys will be interested. That glucose, so the sandwich, the bread gets digested to glucose. Glucose actually travels from the intestines through the blood vessel system, okay, which is kind of like the highway of the body. And it goes to organs for utilization as fuel. And the main organ that actually takes up glucose for fuel is your muscle. Makes sense. Your muscles have a lot of demand on them to use energy. And so glucose mostly goes to muscle. And then there are all your other vital organs that need glucose for fuel. And so the vessel system, the arteries of the body, take that sugar that you just got from your food, your carbohydrate, and brings them to all the organs that need it for energy. Now, getting a little bit more complicated, there is a molecule called insulin. And insulin is called a hormone. It's a fancy word for a messenger in the body. It's a messenger. And it's actually made by the pancreas, which is an organ that sits kind of nestled by the stomach. And insulin is actually released into the bloodstream as a response to eating carbohydrates. Your body's smart. It knows that carbohydrates coming in, and then insulin is made by the pancreas or released by the pancreas. And insulin is actually like a key. That's why I have a picture of a key here. It is a key that opens the door to the organ cells so that glucose can go inside the cell or of like the muscle, for example, and be used. So the insulin's necessary for the glucose to go into the organ so the organ can use it for energy. So what happens? So diabetes is essentially a disease of insulin deficiency, either full insulin deficiency or relative insulin deficiency. And if insulin is deficient, okay, the glucose you just ate from that sandwich has nowhere to go because it cannot go into the muscle anymore or whatever organ it wanted to go into because that key isn't there or there are not enough keys around. And so the glucose, instead of going to where it needs to go for fueling your bodily functions, stays in the bloodstream. And that is where diabetes starts to wreak havoc on the body. So unutilized glucose, so glucose that's just circulating, has nowhere to go. It starts to damage the highway system. It actually starts to damage the vessels that it's sitting in. And that's what causes the complications of diabetes, okay? And so when doctors think about complications of diabetes falling into two categories, complications of small vessel damage and large vessel damage. There are small vessels in our body and there are large vessels in our body. And these vessels kind of fuel different types of organs. So examples of small vessels are ones that are vessels mean like arteries, you know, that carry the blood and the nutrients. Ones that carry the blood and nutrients to nerves are small. The ones that fuel our eyes or feed our eyes are small. And the blood vessels that go to our kidneys are small. And so diabetes affects these organs first because the smaller vessels are more vulnerable to damage. So in diabetes, if the sugars remain high, now of course it's, the sugars remain high, we're able to bring sugars down with treatment. But if the sugars remain high, you can see things like damage to the nerves called neuropathy, damage to the retina of the eye, which is called retinopathy, and damage to the kidneys, which is called nephropathy. And then there's also damage to the larger vessels, and larger vessels fuel the brain. So you could see stroke. And also larger vessels fuel the heart. And so you can see heart disease as a consequence of high blood sugar levels. And just to backtrack, the high blood sugar levels are due to either a total lack or relative lack of insulin, which is the main sort of event that happens that causes diabetes. In addition, if you have diabetes, you might know this, that high sugars in the short term can cause dehydration because your body's actually doesn't know what to do with all this high sugar. And so it urinates out the sugar as much as possible. And with the sugar comes water. And so you become dehydrated. High sugars impair your wound healing. So you can get infections and you can get wounds that are slow to heal. So these are the reasons why diabetes is important to treat. So why does diabetes happen in the first place? So there's a type of diabetes I'm just going to talk quickly about because it's a minority cause of diabetes, but it's type 1 diabetes. And type 1 diabetes can happen in kids. It's sometimes called juvenile onset diabetes, but it actually can happen in any age all the way to, you know, someone who's 90 years old. Any age can be affected by type 1. It's just that if it can also affect kids. So people think of it as a childhood diabetes. But it is a result of your own body's immune attack on the insulin producing cells in the pancreas. So it's an autoimmune condition. So your own immune system is confused and it thinks that the insulin producing cells are like the enemy, like a virus or a bacteria. And so it destroys all the insulin producing cells. That's type 1 diabetes. Type 1 diabetes is less than 10% of all diabetes in this country. The overwhelming majority of diabetes in this country is type 2 diabetes. Type 2 diabetes is a combination of two things. One is insulin resistance. So your body's like making insulin, but your organs are not responding well to it. And beta cell dysfunction it's a fancy word for the beta cells that make insulin are not working very well. And so you have an underproduction of insulin. So not only are you resistant to insulin's actions, you're not making enough. You have a combination of the two, and you become relatively insulin deficient in that way and develop diabetes. So this is indulge me, these are pathologic slides, but I thought people might find this interesting. So this is a section of the pancreas, and the brown staining cells are insulin producing cells. And this is the islet of Langerhans for anyone who has been in the healthcare field or in science. And so you see a bunch of healthy brown staining insulin producing cells. And you compare that to a section from a pancreatic section from a person who had type 2 diabetes. You can see the brown staining is much less. And then in type 1 diabetes, they really have very few brown staining cells. You see one there. But in type 1 diabetes, the destruction of the beta cells is fairly complete. So you have a loss of insulin production in diabetes. This is just another nerdy slide about the reduction of beta cells in type 2 diabetes. So this is actually a graph of pancreatic sections of people who had died of other causes. This is done in Rochester, Minnesota. And when they looked at the pancreases, they would count the beta cells. The beta cells make insulin. And the white bar is no diabetes. You can see they have lots of beta cells, really tall, bar there. Impaired fasting glucose is pre-diabetes. And so you have a reduction in the beta cells. And then type 2 diabetes, you have the least amount of beta cells. So there's a loss of beta cells that make the insulin, plus in type 2 diabetes and pre-diabetes, you're resistant to the insulin. So whatever insulin the body's trying to make, it's not actually working very well. So why does this happen? I didn't actually put a slide on this, but I want to take a side step and say that, you say, why are people insulin resistant? It's really a lot of these risk factors. So when you're overweight and obese and you have excess fat weight on the body, especially in sort of that visceral component around the abdomen, that causes insulin resistance. You also might have, if you have too much fat on the body, the fat can deposit in muscles and in liver and make those organs resistant to insulin. So overweight and obesity is a reason for insulin resistance, or cause of insulin resistance, which is why obesity and overweight are so closely tied to type 2 diabetes. Being sedentary makes you insulin resistant. When you move your muscles, they become sensitive to insulin. If you don't move them at all, they become resistant to insulin. So being sedentary is a risk factor. Genetics are a big risk factor. So if you have a family history of type 2 diabetes, there is some sort of genetic predisposition to insulin resistance or inability to sort of keep your beta cells healthy. So there's a strong genetic predisposition. Non-white racial groups are at higher risk for type 2 diabetes. This includes African American, Latino, Asian, and South Asian, East Asian, Pacific Islander, Native American, all at much higher risk. Probably due to differences in body composition, having more fat on the body, despite lower weights actually, and also genetic factors that have to do with just insulin resistance and the ability to make enough insulin. Obesity and diabetes has always been linked epidemiologically to lower educational status and lower household income. So it's a disease that afflicts people of lower socioeconomic status for various reasons. So who should be screened for diabetes? I think this is a really important part. I think I really should be like, who shouldn't be screened for diabetes? Because I feel like everyone needs to be screened. Looking at this list of risk factors. But if you are overweight, which means you have a body mass index, which is your weight divided by your height squared, of 25 and higher, or 23 and higher if you're Asian, because Asians have more body fat despite lower weights, and you have one or more of these risk factors, so a first-degree relative with diabetes, a high-risk ethnicity, which is non-white, a personal history of cardiovascular disease, a history of hypertension, having high cholesterol, so low HDL, which is the good cholesterol, or high triglycerides, which is the blood fats. If you're a young woman and have been diagnosed with polycystic ovarian syndrome, which is linked to insulin resistance, and if you're over the age of 45. So I screen everyone. I mean, I don't even do primary care, so I don't have a chance to screen, but I would say, like, I don't know who shouldn't be screened. I think mostly everyone should be screened at least once a year, if not more frequently, for the presence of diabetes. If you have had blood tests for diabetes, people might be curious what kind of thresholds you're looking at here for diagnosing diabetes, and it's a table of pre-diabetes and diabetes. So your doctor might order a fasting glucose, which is when you go in fasting overnight and get a blood test in the morning. Pre-diabetes would be a level of 100 to 125, and diabetes would be over that. And a lot of times people are diagnosing diabetes by A1C, hemoglobin A1C. And the pre-diabetes range is 5.7% to 6.4%. And diabetes is 6.5% and higher. If people are wondering what hemoglobin A1C is, it's actually your hemoglobin, which is it's a protein in your red blood cells. You might get it checked to see if you have anemia, for example. Seems unrelated to diabetes. But hemoglobin actually has glucose attached to it at a certain percentage. And that percentage is related to the average glucose level in the blood system. So the higher that percentage means that the higher amount of blood glucose is circulating around. You might actually be diagnosed with a random glucose, meaning just any old time of the day, your doctor draws a glucose level, and if it's greater than 200, that's diagnostic of diabetes. And then at the very bottom, I put the oral glucose tolerance test, the OGTT. No one really does that anymore, except for in pregnancy. But if you have that test, there are some parameters for diagnosing diabetes. But most people are going to get either the fasting glucose ordered by their doctor or that hemoglobin A1C measurement. And when we think about treatment goals of diabetes, as I said, the danger of diabetes is how it affects the vessels. And so the retinopathy of the eyes, the nephropathy of the kidneys, the neuropathy of the nerves. And this is a graph taken from the Diabetes Control and Complications trial, which is actually done quite a long time ago at this point, in the 1990s, which showed that if you can get your A1C down. So the graph on the line on the bottom is A1C level. and risk of complications on the vertical axis there, you can see that the lower the A1C, the lower the chance of complications. And so though diabetes can cause complications, you absolutely can prevent complications by reducing your glucose level to a healthy range. And that range is an A1C of less than 7%. It also includes other important things that protect your organs, like keeping blood pressure under control. And we define that as less than 140/90. And then also keeping cholesterol under control. And these days, we are widely recommending the use of statins in anyone who has diabetes. If you have diabetes, you want to make sure that your doctor and you are always looking for early signs of complications so you can intervene and prevent more serious complications. So there's an annual retinal exam of the eyes, annual check for a protein leak in the urine, which would be early sign of kidney damage, and a foot exam at every visit. Okay, so this talk also promises a discussion on the prevention of diabetes, and so I'm a diabetologist. I see people who already have diabetes and who often have very severe diabetes, but I can't say enough about the importance of diabetes prevention. I would rather go out of business than continue to have referrals because diabetes is so preventable. It is highly, highly preventable. You look, going back to that very first graph I showed you, where in the 1950s, 1% of Americans had diabetes and now 10% do. That isn't a change in our genetics. Genetics don't change that quickly. It is a change in our environment. There are probably multiple different factors that go into how our environment has changed, but the biggest way it has changed is how we eat and how we move. And so this study, I'm showing you a graph from the study called the Diabetes Prevention Program. It took individuals who were overweight and had pre-diabetes already, and they randomized them into 3 arms. One was a placebo arm, so they got nothing. The second was the metformin arm, so they took metformin, which is a drug for diabetes. And the third arm was the lifestyle arm. In the lifestyle arm, people were put on a low-fat, lower calorie diet with the aim of losing 7% of their current body weight. And they were told to exercise 150 minutes per week in a moderately strenuous fashion. Moderate strenuous is like, when you're exercising enough where you kind of break into a little bit of sweat, it's harder to talk, and it's your heart is racing a little bit. And lo and behold, so this graph shows cumulative incidence of diabetes on the vertical axis and years of follow-up on the horizontal axis. And you can see that the placebo arm did the worst, so they had the highest rates of diabetes, followed by metformin. But the best performing arm was the lifestyle arm. And so diet and exercise did the absolute best in terms of preventing diabetes. And so remember, the 2 key parts of lifestyle arm was they lost about 7% of their current body weight with diet. Although, and in this study, they used a low-fat diet. I would say any diet would probably be fine, so long as it's a healthy, lower-calorie diet. And they also exercised 150 minutes per week, which is about 30 minutes a day. And type 2 diabetes can also be greatly improved with lifestyle changes. So, in type 2 diabetes, there's so much involved. There's the checking of the blood sugar. You might be taking injectables along with pills. But the diet and the exercise are almost, or maybe even more important, I would say. And I've been practicing diabetes for over 10 years, and I would actually put lifestyle above medications because, one, there's no medication that will overcome a very poor diet, a very unhealthy diet, and it just changing your diet. It sounds simple, but it's hard. And exercising more is like a miracle. It's when I see that happening in my patients, the glucose improvement is dramatic. It's just hard to do. It's harder to actually change your lifestyle than it is to take a pill, I think. Fortunately, I'm no different. And so, but type 2 diabetes can absolutely be improved and reversed with the same kind of lifestyle changes that I described for diabetes prevention. So lifestyle, it's not, I'm not here to say there's a specific food that prevents diabetes or there's a specific antioxidant or a supplement. Really, it's just good old fashioned eating healthy, losing a few pounds and exercising. But it's a miracle when it comes to treating and preventing diabetes. So in summary, this is actually my last slide. Diabetes is an ever increasing problem in the US and globally. I didn't give you the global stats, but the biggest producers of diabetes in this world are China and India, actually. So it is a tremendous problem across the globe, not just the US. Diabetes is a problem because it impairs health by causing damage to vessels. So the small vessels of the eyes, kidneys, and nerves, the big vessels of the heart and the brain. And most importantly, I think type 2 diabetes, the most common type of diabetes, is preventable and treatable with diet and exercise. And I'm happy to entertain questions about what type of diet, but so long as it's balanced and healthy, all diets in that category are probably going to be effective, and exercise. So that's it. I'm happy to take questions, Carrie.
Great. Well, we've got them coming. And this is,
All right.
I love to hear you just say it over and over again, eat right and exercise. It's such an important message to hear. So thank you. We have a lot of questions.
Okay.
So from Susan, she asked basically, could does age, stress of a blood test, and something like stevia cause a rise in fasting blood glucose? Okay,
so everything, some things get better with age and some things don't. So one thing that as we all age, we become more insulin resistant. And that's probably because as we age, our body composition changes. As we age, we have less muscle. So more muscle makes us, less muscle and more body fat makes us more insulin resistant. And we probably become more sedentary as we get older. So absolutely, age is a risk factor for diabetes and insulin resistance, and therefore, abnormal blood sugar test in the morning. Stress can raise your blood sugars, and the way it does it is through insulin resistance. So when you're stressed, whether it be from physical stress or emotional stress, your body doesn't know the difference. It thinks it's in a life-threatening situation. And when that happens, it thinks it's running from a lion or whatever. It actually makes you insulin resistant because it wants to shunt glucose away from your muscle into your brain so you can think. And so in that situation, you become acutely insulin resistant if you're stressed, and then you can have a higher sugar level because of stress. You see that really more in people with prediabetes or diabetes, where the insulin production is not enough to overcome that insulin resistance. And then stevia shouldn't raise your blood sugar. It's an artificial sweetener. It's non-caloric, and to my knowledge, there's been some press about or studies about insulin resistance caused by artificial sweeteners, but the sweetener itself is not sugar, so it should not actually raise your blood sugar.
Okay, great. Earlier, you did point out the MGDL readings ranging from 1 to 125, and then for full diabetes greater than or equal to. So there's a question about this. Some say 100 or less is okay. Some say 120 is less. So how do you know what is best for you? And then the fasting number first thing in the morning seems most important. What should be, is that true? What should be our goal to achieve that number? I notice it varies depending on the time, what I consumed that day, and more activity equals lower number.
Yeah. Okay. So those are great points. So, So anything above 100 is considered to be abnormal. And so, but we don't put that in the diabetes range. And the reason why there is like that pre-diabetes category to even begin with is because what doctors and scientists try to do is actually come up with the threshold in which you will have a significant increase in complications. So at those levels, you have a statistically significant increased risk of complications compared to someone without any glucose abnormality. And that's why those thresholds exist, but they're just numeric thresholds, right? And so it's really a spectrum. The higher the blood glucose, probably, the worse it is for your health. So you can pick your threshold of 100 or 125, and doctors have a reason to say then, okay, that's pre-diabetes or that's diabetes. But once you see it creep above 100, that is cause to sort of think about, okay, I have pre-diabetes or I have some sort of glucose metabolism abnormality, probably have some insulin resistance. This is the time to sort of do something about it. In response to your question of whether fasting glucose is more important, it's probably whatever the glucose is on average all times of the day. Your fasting glucose is actually more reflective of your liver. It's kind of complicated, but your liver is actually in charge of glucose levels when you're fasting. It stores extra glucose and puts it out as needed. And so if you have more liver insulin resistance, your fasting glucose tends to be higher. If you have more muscle insulin resistance, your post-meal glucose tends to be higher. So they're a little bit physiologically different things, and they're both important.
And so depending on which one you have, it varies by person, whether it's
it varies by how much insulin resistance you have in those organ systems.
Okay. So Joan is asked if the carbohydrates I consume, she's just been diagnosed with pre-diabetes, if the carbohydrates she's consuming come from whole grains, fruits, and vegetables, do I need to further restrict the overall amount of carbohydrates? If so, is there a target range?
I don't think that for someone with pre-diabetes, you need to start restricting carbohydrates. When I think about restricting carbohydrates, I think about people who are on insulin, who take maybe insulin for their meals. So I think if you choose healthy carbohydrates, which she's named, so fruits, like whole fruits, not fruit juice, whole grains. So so the brown rice, the whole wheat pastas, the whole grain breads. Always read the label, because sometimes whole grain stuff has added sugar to make it taste different. So always read the label. Make sure whole grain products have high fiber. So you want to look at fiber content in your food. And dairy without added sugar. So the yogurts without the added sugar, etc. So I think the quality of the carbohydrate is much more important, especially in pre-diabetes, when you really do have quite a good capacity to make insulin. The reason why those carbohydrates are healthier is because when you digest them, they actually digest very slowly given their fiber content. And so your body doesn't have a sudden surge of sugar in the vessels where the pancreas has to respond to it very briskly. It's a very slow release of the glucose because of the slower digestion because of the fiber content. And so the body can absolutely handle that. If you're drinking just like Coca-Cola, that is like just mainlining sugar right into your body. Your pancreas, especially if it's already pre-diabetic, can't handle that surge. And so that's why those carbohydrates, the healthier carbohydrates, are better.
Okay, great. There's the question about statin. If that could be, sounds like everybody's on them. So if that could increase in your levels, cause.
Yeah. So it's recognized that statins increase insulin resistance to a small degree. And so if you have diabetes or you're monitoring, you might see a little difference in your glucose levels once you start statin. The benefits of the statin are thought to outweigh that increment in insulin resistance, but it is an observed phenomenon.
Okay, you talked a little bit about the cause of diabetes, but Sandra's asked what the root cause is why is a lack of insulin production or why insulin resistance? If there are medical means to discern the cause of a person's diabetes, what is it? How can a person obtain testing? I think you kind of talked about that to a certain extent, but
Yeah. So those are really great questions. So, so why the insulin resistance? So as I said, the body fat in sort of the more metabolically unhealthy areas, like the viscera, which is in the area of the tummy where the digestive organs sit. Also, fat accumulation in the muscles, fat accumulation in the liver causes insulin resistance. It causes the insulin to not work very well. The reason for the beta cell inability to make insulin is largely genetically influenced, to my knowledge. So your body has a certain capacity to make insulin in the face of insulin resistance and insulin demand. And genetically, you may be born with less of an ability to mount a big insulin response to increasing insulin resistance. And then what was the other question about?
I think that was about it. Is there medical means to discern the cause?
Yeah, so you actually can get insulin levels drawn, and you can get C-peptide levels, which is C-peptide is the breakdown product of insulin. You have to have it done in certain conditions, like it has to be fasting, it has to have a concomitant glucose level. You kind of have to have a physician who's going to know how to interpret that, because it's not a really commonly obtained blood test. But yeah, there are ways to measure insulin resistance versus sort of like beta cell failure.
When the incidence of diabetes increased over these last 50 years, did the incidence of type 1 remain constant?
So actually, type 1 diabetes is also slowly increasing for a totally different reason. Because as you know, type 1 diabetes is an autoimmune disease, but autoimmune disease is actually increasing in this country or in the world. And the reason they think, not totally verified, one reason is sort of the sanitation theory, which is that we're becoming more and more sanitary. We're not exposed to viruses and bacteria. And I was thinking like during the COVID pandemic, whether type 1 will surge or spike. But the theory is that when your body isn't busy fighting viruses and bacteria, it starts to wreak havoc with its own body. And so there's a sanitation theory about why we're increasing in autoimmune conditions. So both of them are increasing, but type 2 is much more.
That's related to the question that was asked about, what's your opinion on diabetes as a possible autoimmune disease, and therefore probably leads to a different prescription drug for treating type 2 diabetes?
That's a pretty nuanced question about whether there could be some autoimmunity in type 2 diabetes.
Okay, so perhaps different. Okay,
yeah. A little beyond my scientific knowledge.
Okay. This person asked, kind of specific, if a person is on a daily 1,000 milligrams of metformin supplemented with an occasional half pill of glipizide for type 2, is the person considered immunocompromised, even though HA1C shows the diabetes is under control by taking metformin and glipizide?
Yeah. So I asked, and especially during the pandemic, that question has come up so much for my patients, like, am I immunocompromised? And so my answer to that is your immunocompromised status is directly related to, or most related to, your glucose levels. So what happens is that when you're hyperglycemic or when you have high glucose levels, the white blood cells that fight infection are not performing well. And this is because their ability to chemotax, it's like their ability to talk to each other, to say, hey, this is where we all need to go to fight that infection in the lung or wherever, that communication is impaired. And so it's really a glucose level issue rather than having diabetes per se. And so if you have type 2 diabetes and you're on metformin and you're on a little occasional glipizide and your glucoses are essentially normal because you take the medications and you're on it with your diet and exercise, I don't think that you're at a higher risk of infections compared to someone who doesn't have diabetes. That said, in the time of COVID, we know that diabetes is a risk factor for worsening COVID outcomes, not higher infection rates, but once you have COVID, you may have a more severe outcome. And that's a bit more complicated. That might also be related to other risk factors for worsening infections like hypertension and obesity. So with the COVID situation, it's a little bit different, but in infections in general, it's really related to to the glucose levels.
Great. Are there let's see, what are the healthy and unhealthy carbs? And then sort of related to that, carbs and starches, are certain starches more harmful than others if you try to prevent diabetes, for instance, brown rice versus white rice, yams versus white potatoes? So there are two questions about nutrition there.
Yeah, so I think as long as you're eating, okay, this is what you shouldn't be eating: beverages with sugars in them. So and then really it's the processed foods that are unhealthy, you know. So it's stuff with added sugar in it, or it's stuff with very highly refined grains like candy bars, but you have to be careful because even granola bars have as much sugar as candy bars. So you got to look at the labels. Cereals can have just as much sugar as like a cup of soda. So you have to look at the labels. But generally it's processed foods. If the wholer and unprocessed the food is, even if it's a yam and it's full of carbohydrates, it's going to be a way healthier carbohydrate than a potato chip. If it's a natural fruit or vegetable, and then if it's a grain that's minimally processed, the less processed, the better. It's going to be fine. It's going to be okay, especially in prediabetes and mild type 2 diabetes, where you're not like fussing with multiple insulin injections per day. And that's a completely different area. But yeah, so unprocessed, minimally processed.
This is interesting. This person, after they retired, they increased their exercise 360 minutes a week. They ate well, they lost a little weight, but their blood sugar increased. And I hate this reason that people give. When they went to the Kaiser class, they attribute it to aging. It was quite depressing. So I find it a little disturbing when people just say, "Oh, you're old." I can't imagine it's that simple. You have any? I laugh.
I mean, that's really interesting. If that person, okay, so the main determinants of, you know, insulin resistance, as we talked about, are exercise, weight. So I don't know if there's been any weight change, if there's been any dietary changes. When someone retires, those things can happen. So I'm talking about lifestyle, as you know, as opposed to just aging. But it depends. I mean, if it's a mild increase in the glucose, we can attribute it to lifestyle factors. If it's a significant increase in glucose, then the doctor really should be looking for secondary causes, because there are other reasons why you get diabetes. I didn't go into it, but like, could it be, if it's a dramatic increase, could it be nuance of type 1, or could it be a pancreatic process? So that's, you know, if it's very, very high or very, very different, it could be a different cause. But if it's just a slight increase, it could be lifestyle related, because there's nothing magical about the age in which you retired, the day before you retired, right? I mean, it's a process. So I'm thinking my best guess would be a lifestyle change.
Okay, great. If one has an elevated HbA1c, and how is it determined whether it is type 1 or type 2, since so not only juvenile onset?
Yeah, so type A1C does not tell you type 1 versus type 2. It just tells you sugar level. It doesn't tell you etiology. If you wanted to know the cause of the diabetes, it's mostly a clinical diagnosis, but if you wanted to confirm type 1 diabetes, there are antibody level. There's another set of tests that you would do to look for type 1 diabetes. But the thresholds to answer that first part of the question is 6.5 and higher is diabetes. Okay,
great. How should testing be used in cases of low pre-diabetic levels, for example, frequency?
You mean home blood sugar level? You know, I think that testing at home for pre-diabetes is really more kind of like informing yourself how different foods affect your blood sugars. So more like teaching yourself, like, hey, if I eat like this whole plate of pasta, like, what is my blood sugar later? Is it okay? Can I handle that? Or like, you know, chocolate cake or something, you know, or versus like, how does exercise affect my blood sugar levels, you know, probably in a good way. So that testing your sugars in pre-diabetes is more of like self-education and sort of tweaking your lifestyle and diet to sort of optimize diabetes prevention.
Okay, we've had a question on what are your thoughts on keto or lower carb diets?
Yeah, so that's so full disclosure, I co-investigate on, I'm agnostic to what diets, but like I do co-investigate on a ketogenic diet for type 2 diabetes that's done at UCSF, and Rick Hecht is the PI for that. So I will say this, is that I think you can do a ketogenic diet healthily. I think it has to be something thought about, you know, carefully. I think it would help to meet with a dietitian if you're going to go into that ketogenic low carb, very low carb diet, just so you don't miss major nutrients in your diet. And then also just tell your doctor so they can be aware of some of the consequences of ketogenic diet, which could be a raise in your cholesterol level because you're eating a lot more fat as opposed to carbs, right? And then there could be some alterations in the medications you take because you go on a ketogenic diet. So I don't think there's anything wrong with it. I think there are healthy ways to do ketogenic and unhealthy ways to do ketogenic. And so it's best to do that with your medical team.
Any thoughts on cinnamon pills, omega-3 fish oil that can help manage the glucose levels?
I haven't seen really consistent data about omega-3s. I mean, omega-3s are really great for lowering triglycerides. They're usually used in the context of cholesterol lowering. And so that might be valuable to someone because of cholesterol lowering or triglyceride lowering in particular. I haven't seen a whole lot in terms of diabetes improvement with fish oil. I've heard of and seen some stuff about cinnamon. I think you have to take a lot of cinnamon in order to lower that glucose. I have to say I haven't had personal witnessing of a lot of success using high dose cinnamon. I think like if you just sprinkle it on your oatmeal, I'm not sure it's going to make much a difference. You probably have to take cinnamon pills or something to really make a difference. And it probably, if it does make a difference, it's probably going to be effective in the mild cases, but not so much when you have like sort of full-blown diabetes.
Okay, right in that, have you heard of the Whole30 diet? Is that okay, given that it's not a low-fat diet?
I've heard of Whole30. I think it has like no sugar, so I don't know very well, but I don't, something you do for 30 days that kind of eliminates processed food probably is fine. What was the question about it? Oh, because it's not low fat. Yeah, I mean, fat in and of itself is there's good fats and bad fats. So let's just put it that way. So there are fats that come from fish and nuts and avocados and olives that are actually probably good for your body. And then the saturated fats, it's just debate on whether saturated fats are good or bad. I think it probably is a decision that you make on an individual basis, depending on their other medical conditions. So I don't know enough about Whole30 to answer that question, just rambling, but there's good fats and bad fats. You could probably do the Whole30. So if you're ever going to do a fad diet, I'm sorry, it's not fad, I don't know, it's 30 days. But if you're ever going to do a diet that's very different from the one you are on, and especially cuts out a lot of carbohydrates, you just need to tell your doctor first, because you may be on a medication that assumes some level of carbohydrate consumption. And especially if you're on a medication like insulin or sulfonylurea that can lower your blood sugar levels to a dangerous level, you might need adjustment in those medications before you embark on a diet. That's why I always say, like, ask your doctor. It's because of that. You want to make sure you're not taking medication too strong of medications for your new diet.
Okay. For seniors over 70, can the BMI be higher than 23 for Asians? How do you adjust for seniors?
Oh, it's interesting. I would say that, so this is a couple of things I think about seniors. So if you have reached seniorhood, so say like arbitrarily above 65, and you don't yet have diabetes, okay, you've shown the world and yourself that it's fine. Like your body has been fine for 65 years. And if you're already overweight, usually people at that age, 65, what I've seen is that they don't suddenly gain a ton of weight when they're in their 60s and 70s and 80s. It's usually, a carryover from whatever they were in adulthood. So if your weight's stable and you don't yet have diabetes and hypertension, the chance of you getting it are much less than if you already had the disease younger in life, right? Because not everyone has an equal propensity to getting these conditions. There is a very strong genetic component to it. And so if you're 65 and already free of a lot of chronic conditions, it's a good sign. You don't necessarily need to lose weight now. I would do it as a individualized sort of decision making based on blood test level. So if your doctor says, oh, by the way, your A1C is creeping up, then I would probably incorporate some exercise, maybe try to lose a little bit of weight, but to not really judge and define your health status on the BMI alone. You know, the BMI is just your weight, it's which is a pull of gravity onto the earth. And so it doesn't actually tell you body composition either. So if you're very muscular, you could have like a higher BMI, but it's not actually unhealthy, right? So these are really broad sort of recommendations, but these are discussions you probably should have with your individual healthcare provider.
Helpful. What are the role of vitamins like B12 have in diabetes management?
So B12 is an important nutrient to just keep in mind in diabetes because metformin, which is the most popular drug to treat diabetes, can cause B12 deficiency, and it has to do with B12 absorption in the gut. And so periodically you may want to get checked for B12. But besides that, not an issue, I think.
Okay, this is interesting. I walk 10,000 steps every day, rain or shine. I do water yoga for more than 45 minutes 2 times a week, but my A1 is 6.4. How can I reduce A1 level?
So you've already maximized your exercise, I think. That sounds incredible. So then you would look at, are there ways to modify the diet? You know, nutrition consultation could help with that. Are there refined carbohydrates that are being eaten or added sugars that are being eaten? Even natural sugars, I forgot to mention that, like honey and agave, they're all sugar. So is there dietary things you can leverage? And then sometimes, you know, people, so if you have weight to lose, like if you're overweight and obese, even if you have a very healthy diet, it could be just, you know, overconsumption of healthy foods can also cause weight gain. So, you know, do you have some weight to lose, and would something like reducing your portions would help you to lose weight and lower that number? Yeah, so a dietitian, I think, would be your friend in sort of strategizing around that.
Carrie and Dr. Kim.
We're going to wrap up. I just want to say one more thing. No more questions. And we have so many questions. So what would be the best way for people to continue learning about this? How they might, how we might direct them with all the questions that they
have. So we have a website, which is the Diabetes Teaching Center. It has a lot of stuff on diabetes, actually. It's really information dense, sometimes too much so. So that I would point them to our website. I don't know if you had questions.
I put
the website address. I mean, just Google it really quick.
Yeah, like that. And then while you're finding that, Dr. Kim, there, Ann Lynn, thank you so much. Put it in there. Thank you, Ann. The UCSFhealth.org Clinics Diabetes Teaching Center. So there's your
great, wonderful.
Yeah, this has just been wonderful. And I'm so sorry we couldn't get to everybody's questions, but we have a hard stop today, and we also want to first we want to thank Dr. Kim. She's got another meeting to jump off and go on to. So, and then we'll continue on to learn more about Belmont Village's programs, especially around diabetes. So, but I will bid you adieu and thank you, Dr. Kim. Appreciate it.
Thanks for having me. It was fun.
Dr. Kim, we're going to have you back. There's still like 30 questions.
Just Q&A, just Q&A.
Just Q&A.
Somebody told me you should have your own channel on TV. So just throwing that out there. It's been so helpful. We know you have a hard stop. We really appreciate your time.
No problem.
And I love what you said, how you would rather go out of business than to keep having people get diabetes.
Absolutely.
So
all right,
we don't want you to go out of business, but we will take better care of ourselves.
Thank you. Take care. Bye-bye.
Thank you too. And now, ladies and gentlemen, oh my goodness, we really wish we could have gone on, but Dr. Kim really did have another meeting to attend at 12 o'clock sharp. So we wanted to be thoughtful of her time. And if you have a few minutes to stay on, Susan Berger, our family advisor, is going to tell us about how Belmont Village helps manage diabetes. Additionally, this will be our last webinar for the year. So we will circle back around in 2022. It's been wonderful. We have on our website a library of lectures that you can access so much new information that you wouldn't believe, just a wealth of information. We would direct you to the Belmont Village website to look up the webinars there. You're all invited. And without any further ado, Susan Berger, please take it away.
Thank you, Jackie. Well, for 24 years, all of our Belmont Village communities promote the quality of life. We know and we feel it's about health, energy, and purpose. We want all of our residents to stay healthy and active, and in so doing, to live well. Our residents receive help with activities of daily living as needed. And although their needs may vary, they can count on our caring and compassionate staff who are committed to providing high quality, person-centered care. But our residents can also count on our Belmont Village nurses. These are trained medical professionals who are dedicated to serve the healthcare needs of each resident. And for seniors living with diabetes, moving to a Belmont Village community does not mean that this disease will in any way detract from their independence or happiness. Equipped with the proper knowledge, like we've heard from Dr. Kim, and a willingness to maintain one's health and open lines of communication with our team of nurses, this disease can be managed effectively and residents continue to live happy and successful lives. Belmont Village has been recognized as a center for diabetic excellence because our team of trained nurses have specialized training in diabetes care. They can monitor glucose levels and blood pressure and can also administer insulin injections. And above all, they're keen observers and can quickly assess changes in residents' health. Most importantly, they're there 24 hours a day to provide peace of mind, not only for our residents, but for their families as well. We know at Belmont that what you eat and drink and how much you exercise and the way you socialize are all equally important. We have a chef who does 25 different menu selections, and anyone adhering to a diet, such as our diabetic residents, can do so successfully. But we also know that successful aging involves staying active. Whether our residents want to kickstart their days with group fitness or one-on-one exercise, our goal is always to stimulate them through their minds and body at whatever level they feel successful. And what better way to stay physically engaged than under the watchful eyes of our team of licensed physical therapists on site. We have a state-of-the-art gym as well, equipped with great senior-friendly equipment. I'd love to talk a little bit about our memory care program. Many residents who are at Belmont Village have peace of mind knowing that we are there to support them, from very independent residents to those who experience mild cognitive impairment or more moderate to advanced stages. And for everyone, we provide what we call just the right challenge. I would love to speak to you more about our circle of friends, because that is for those who are more mild to moderate. And this program is changing how providers and their families look at assisted living and memory care today. We try and create a positive experience for all of our members. Those include our residents, their families, and our employees. And I'm proud to say we set new standards in resident and family satisfaction year after year. My name is Susan Berger, and I am a trusted family advisor. It's always my pleasure to assist families as they navigate the many options in senior living, either for themselves or for their loved one. But if you have any questions about Belmont Village, about diabetic management by our team of nurses, I do hope that you will give me a call or send me a text. My phone number is 424-232-0701. And my email is sberger@belmontvillage.com. Thank you for joining us today. Thank you for enjoying a year of wonderful seminars. And we look forward to seeing you again next year. Jackie?
We sure do look forward to seeing you next year. Susan, thank you so much. Happy holidays, everybody. Have a happy Thanksgiving. We are so grateful for Belmont Village and our relationship with UC Berkeley. Thank you, Carrie, as always, for helping us bring such wonderful talent that we can share with our residents, family, your retirees, of course, and the public.
Absolutely. Thanks, Jackie. It was good, fun, learned so much. We'll have to have Dr. Kim back. She was very informative. And thanks, Susan, for sharing that with us. I think it's an important information for people to know how Belmont stands out from others. So thanks so much.
You're welcome.
Thanks, everyone.